All right, I am getting ready to start my system up here. Great, thank you, Laura. Nice to see you. I appreciate the introduction and appreciate the opportunity to once again collaborate with Doctor's Data, who is got a host of a long menu of services that I and hopefully all of us take advantage of. And I want to thank them for being a sponsor of the Institute of Women's Health and Integrative Medicine, and in which we have 4 seminars a year, and they also contribute speakers to those seminars, and we have one coming up at the end of July. So you might want to check that out. But thank you again for the opportunity, and to the team at Doctor's Data, and I'm going to try to get my slides done in about 60 minutes, and then we'll have a few minutes for Q&A. So we might go as long as 75 just to let everybody know. Alrighty, so here we have that. We don't need that. There is a disclaimer around information on the webinar that is obligatory here. I do have disclosures. The most important today is on the Speakers Bureau for Doctors Data. We are going to obviously talk about botanicals that many of these companies offer products with those botanicals, but we're not talking about any specific proprietary products. Okay, so when you go to develop a list where you want to boldly say these are the top 10 herbs in women's health, we could fuss with this list, and your list might be slightly different, but the important thing about the list is when you see my assertion is it's not just the herbs that are used in gynecology or female endocrinology. It's really women's health is by definition problems that occur only in women, problems that occur more often in women, and the list of that is long, and then problems that have some unique manifestation or distinction in presentation and diagnostic criteria such in women. So the primary care, depression, insomnia, anxiety, constipation, IBS, fibromyalgia, thyroid disease, numerous autoimmune diseases, obviously breast cancer, osteoporosis. These are all primary care issues that occur more often in women. And so that's why you'll see these herbs and some of the studies relevant to primary care issues. So let's start with chaste tree. I think that's a good one to start with, because I think I would guess that everybody would agree that might be in their top 10. In terms of a research overview, it's mostly not primary care, actually, if at all. And we have some particular areas that the research is really strong, like the cyclic mastalgia, which I'll talk about. So these things, the research overview list, let's go through some of those. So these are 5 studies on cyclic mastalgia. And like I said, this is the strongest area of research for chaste tree from what I can tell. And it's been studied in both randomized and non-randomized studies. And you see all 5 of those bullet points, they all show benefit in cyclic mastalgia. And not every single study had the same dose, but at least 58%. That's the worst case scenario of patients treated with chaste tree had an improvement in their cyclic mastalgia. And that is, when you, I would say, my subjective reporting is about 80% of women would get better who had cyclic mastalgia. I do like to, when someone has really, if they're not in that 80%, then you might think of this particular kind of iodine called violet iodine. And that is proprietary, but I have nothing to do with them. But it doesn't have any negative effects on the thyroid gland. So that's why I use that form of iodine. And especially if they have actually, fibrocystic, dense, lumpy breasts, you might want to add the iodine into the picture. So you need to give the chaste tree all month long to get this benefit. You don't just give it part of the cycle. and you have choices of tinctures and capsules and standardized extracts. So the dosing can be confusing, granted. This is a study in Chinese women in PMS, and I'm going to just stop my video since it's distracting to me. I'll come back and forth though. This was 40 milligrams of the standardized extract once a day through 3 cycles, and they used a particular premenstrual syndrome diary score, and it decreased like 5-fold, like from about 29 down to about a 6.5 at the end of the 3rd cycle. And that is my suggestion for treating PMS with any herbal product, is give it about 3 cycles to really fully understand the benefits. Now, if they have severe PMDD, not seeing them for 3 cycles and not adjusting sooner than 3 cycles is maybe is too long, if they have pretty severe depression and or anxiety. And for PMDD, I wouldn't be just using Chase Tree, but the most likely PMS symptom that it's going to help is going to be cyclic massalgia, but not the only symptom, because as you see in this study, the whole scale of symptoms overall improved. Okay, let's look at Vitex and secondary amenorrhea. A small, older study, really older. Women had a variety of menstrual disorders, and 6 of those women had secondary amenorrhea. Why they had secondary amenorrhea, I do not know, but all of them developed 1 or more cyclic menstrual cycles. In another report that was about 30 years ago, a nice little humble 40 drops of a tincture daily in women with secondary amenorrhea, 15 out of the 20 of them had an onset of their menstrual cycles that became regular. Again, in both of these papers, we did not know why they had secondary amenorrhea, and there are numerous causes of secondary amenorrhea. It will only help the anovulatory issues related to secondary amenorrhea. Vitex will not help the premature ovarian failure patient. And I think it would be a tough ask for the hypothalamic amenorrhea patient as well. So it's more going to be the sort of stress-induced related cause of secondary amenorrhea, I think, is where we get our best results, although secondary amenorrhea can be caused by elevated prolactin, and Vitex does suppress pituitary prolactin release. We think that Vitex largely works by stimulating the hypothalamus, and that kind of kicking off that hypothalamic pituitary ovarian cycle, and that's why it helps with ovulation. By doing this, it is really some people call it having a progesterone-like effect. I think that's fair. It's not fair to say that it has progesterone, but what it does is it increases luteinizing hormone production, and then there ends up being this sort of shift in favor of progesterone. So it's a corpus luteum-like hormonal effect. And it's not really a direct, it's an indirect effect, not a direct hormonal action. But it can be used in benign hyperprolactinemia. You have to make sure it's benign. And again, I would typically give it about 3 months to follow the prolactin levels to see that it in fact is decreasing. And again, I would give it all month long. There's a little bit of evidence for use in PCOS, again, because it stimulates ovulation by stimulating luteinizing hormone, but that shouldn't be the core of your treatment for a woman with PCOS. PCOS needs to be addressed for what it is. It's a condition of insulin resistance and hyperandrogenism, possibly some new emerging interesting look at some perhaps inflammatory mechanisms within the ovary, but it's largely those 2 basic mechanisms. So Vitex, it doesn't improve insulin sensitivity, it doesn't improve hyperandrogenism, but if you're doing those other things, if you're doing other therapies for those two mechanisms and adding Vitex, then I think its role in PCOS is relevant. Okay, let's look at black cohosh. So black cohosh, the predominance of research by far is in the realm of perimenopause and menopause. And there's a little bit scattered here and there on some other things. And of course, there's some historical uses that are interesting. I find the one for arthralgias, I didn't list it in the historical uses there, but it was used, at least by, as I understand it, by Native peoples in the U.S., in the Americas for rheumatism. And I have, since rheumatism can be a part of a perimenopause, menopause picture, I think black cohosh is a nice choice for all their other menopause symptoms, as well as that symptoms, as well as the symptom of arthralgia or rheumatism. There is a whole lot. This number is over 100. What is it? Somewhere between 100 and 125. So that's why it's clearly the most published botanical in the realm of perimenopause and menopause. So it's impossible for me to talk about all those things. So I picked out a few, and some of the more recent ones, although even this one is about 8 years old. And this one is sort of interesting because it was kind of such a tiny, tiny dose of 6.5 milligrams of dried extract of black cohosh root. This was out of Iran, and very different than any standardized extract that we're usually looking at, because most of the research we're looking at would be like the 40 milligram standardized extract, which was what I would typically be using. But even with this, and these were postmenopausal women, there was a considerable decline in their vasomotor symptom severity. That's hot flashes and night sweats. So severity reduced, the number of hot flashes reduced at 4 weeks, and even a little bit more at the end of 8 weeks. So, and that's something I tell my patients. We want something to work within by the end of 4 weeks. If it's not working at all, whether it's black cohosh or anything else, we're going to move on to something else. But with black cohosh, and it's not the only one, even with systemic estrogen, they get a benefit at the end of 4 weeks. They will likely get at least a little more benefit at the end of 8 weeks. And then wherever they are at the end of 8 weeks is likely where they're going to be. This was a study more kind of, I would say, demonstrating the safety in breast cancer patients and in fact breast cancer patients who were taking tamoxifen. So it passed the IRB as far as safety goes, and in fact we do have safety information for the use of black cohosh in breast cancer patients, because it's not a phytoestrogen. Even if it was, I'm not sure that I would be concerned at all, given that we're going to be giving soy, one of the most potent phytoestrogens, to breast cancer patients to actually reduce their risk of recurrence. And this has now been demonstrated in 3 very large studies. So I'm not worried about phytoestrogens in breast cancer. But black cohosh doesn't have phytoestrogen. It doesn't have estrogen. It doesn't raise estrogen. In fact, there's a couple in vitro studies that show it inhibits ER-positive breast cancer cells. And in that same one of those studies, it actually augmented the anti-estrogenic effect of tamoxifen in vitro. This was in actual women with breast cancer and on tamoxifen who had problems of menopause symptoms during that time period. And the menopause rating scale score reduced, meaning it improves in a statistically significant way in a multitude of symptoms, including hot flashes, sweating, sleep problems, and anxiety. What did not improve was vaginal dryness, not surprising. What did not improve was body aches and pains. That is surprising, because of what I said earlier. And my observation is that black cohosh can often help that. Here's the first of about 3 studies I have today on black cohosh with St. John's wort. This was in peri and postmenopausal women who had various symptoms, including psychological symptoms. They use the menopause rating scale, a score system, which is a common tool, and they use the Hamilton Depression Rating Scale, which is a common research tool. And the MRS scale reduced 50% in the treatment group, only a little over 19% in the placebo group. And in the depression rating scale score, decreased about 42% in the treatment group and only about 12.5% in the placebo group. So the combination in both the general menopause rating scale and the depression scale, the combination was significantly superior to placebo. So, and it makes sense to me. And if I think I have a little bit later, even just St. John's wort by itself has been studied for hot flashes. In this second study, though, this was looking at a black cohosh alone or a black cohosh with St. John's wort. And they saw improvements in both regimens, but the combination of the two herbs was actually superior to black cohosh alone in alleviating mood symptoms in women with other menopause symptoms. That makes sense to me too, given the research we have on St. John's wort and depression. The third study was carried out in peri and postmenopausal Korean women. At the end of the study, the average decrease in the Cooperman Index, another menopause scale research tool, the average decrease was 20 points in the treatment group and only 8 points in the placebo group. Vaginal dryness and low libido were two symptoms that did not improve. That does not surprise me. But the average hot flash scores were significantly lower in the combination group. So think combination black cohosh with St. John's wort, especially if they have hot flashes, night sweats, and dysthymia or depression. Okay, what about black cohosh and PCOS? This was a study I loved coming across because it wasn't a newer way to think about using black cohosh. This is a 40 milligram black cohosh extract, and they use it for 10 days of the month in the first, what would be the first half of the cycle. And they a different group was given 100 milligrams of Clomid for 5 days. And they were given, the treatments were given on day 2 of each cycle and continued for 3 consecutive cycles. So that's why I say it was in the follicular phase of the cycle. The black cohosh group had a significantly greater reduction in the LH level, as well as the FSH-LH ratio. After receiving black cohosh, this group also had significantly greater progesterone levels and endometrial thickening. So what did it do? It actually stimulated ovulation, and it seemed to stimulate the ovarian. Well, I don't know why the endometrial thickening occurred. I was going to say something, but I'm holding off on that because we don't actually know why that occurred. It doesn't. And there's no studies that I'm aware of that show that black cohosh increases estrogen levels. But we do know that significantly greater progesterone level, that tells us, oh, this one with PCOS ovulated. Hooray. And then I also always love to, but again, back to this, the core issue is using nutraceuticals and botanicals in PCOS patients that improve insulin sensitivity and hyperandrogenism. That's going to be, NAC is going to be at the top of our list. The inositols are at the top of the list. And then we've got a long menu of one-off studies, here and there, marjoram, peppermint, or actually I think it's spearmint, cinnamon, chromium, I'm sure I'm forgetting licorice root in terms of the anti-androgen effect. And I'm sure there's others I'm forgetting. But NAC and the inositols are big. Okay, fibroids. What causes uterine fibroids, we still don't know. This was originally a menopause study in Chinese women who had menopause symptoms, and they were treated with either black cohosh or a drug we don't have in the US called tibolone for 3 months. But this study kind of was a subset of that study. And these were women who had at least one uterine fibroid at the onset of the study. And they compared the effect of the black cohosh on fibroid size to the tibolone. And there was a 30% decrease in volume size in the black cohosh group. And there was actually a tiny increase in the tibolone group. There was also an increase in the percentage of mean diameter change in the herbal group. So volume size and an individual diameter of an individual fibroid. And that was given all month long. So that's very exciting, given that we have very limited proof of any natural therapies on treating uterine fibroids. I'll show you something else a little bit later on green tea. And then St. John's wort. You know, it really, no matter what else is new and shows up in research on depression and botanicals, whether it's curcumin or saffron or something else, St. John's wort is kind of tried and true in my book. And for depressive disorders, especially mild to moderate, but I don't exclude severe. I just don't want to risk someone's life by undertreating them. But this was a Cochrane review, total of 37 trials. And let's see, patients in trials restricted to patients with major depression, the combined response ratio for St. John's wort compared with placebo from 6 larger trials wasn't very impressive, 1.15, so a small impact. And from 6 smaller trials, though, more impressive, 2.06. In trials not restricted to the major depression, the response ratios from 6 larger trials was 1.71, and from 5 smaller, 6.1. Now we're getting significant. And here's the big take home from this Cochrane review. Trials comparing St. John's wort extracts and standard antidepressants showed that they were similar results, equal to the results with whether it was SSRIs or tricyclic antidepressants. The response ratio was the same. That's a wowie zowie, I would say. And we know there are a lot less side effects with St. John's wort by far. That doesn't mean there's never a time and place for the other. Also, I mentioned, and here it is, St. John's wort and just menopause symptoms. And this was old-fashioned tincture, 20 drops 3 times a day. Let's see here. The symptoms the hot flash frequency began to decline during the 1st and 2nd months, but showed more improvement during the 2nd month, which supports what I said earlier. There was no statistical change in hot flash frequency during the 1st month of the placebo, but a little bit in the 2nd month. The duration of hot flashes was statistically significant at week 8 in the St. John's group, and much better than the placebo group. The severity was relieved in St. John's group during the 2 months of treatment, was more significant in the 2nd month. Women in the placebo group didn't really show any significant decrease in severity during the 1st month, a little tiny bit in the 2nd month. But St. John's wort outperformed placebo in all ways, frequency, severity, and duration. Just what you want to see. St. John's wort is definitely in my top 6 ingredients that I need to see in a PMS formula. And this is just one of a few studies. It's 36 women with regular menstrual cycles, mild PMS, St. John's wort, 900 milligrams a day. That's kind of typical, 300 milligrams 3 times a day. It was more beneficial than placebo in food cravings, water retention, poor coordination, sleep issues, confusion, headaches, crying. It was not more statistically significant in anxiety, irritability, and depression. That is super surprising, given that PMS, especially PMDD, is very much a serotonin-related issue, and we know that St. John's wort also impacts serotonin, or we think that it does. So that's pretty surprising. Okay, let's move on to ginger. And of course, there's a whole other things we could say about St. John's wort, but it's largely in my top 10 because of the effect on mood, depression as a primary care issue, and a little bit the menopause PMS aspect. Okay, let's look at ginger. Ginger is it's not hard for me to say ginger is way towards the top of this list of the top 10 because I love the diversity of ginger. And I'll give you a feel for why that is. So we have a lot of historical uses, but here is a wonderful study on acute menorrhagia. Now, this study did not point out why do they have menorrhagia. Would this work as well in fibroids? Would it work as well in a uterine polyp, or is it just dysfunctional uterine bleeding due to anovulation and menorrhagia? We don't know. The study doesn't tell us that. I wouldn't be super confident with the polyp and the fibroid, but just sort of functional. That's not to say I wouldn't, even though I'm not super confident, I'm not going to not try it. But you should not be as optimistic. And in my experience now with it for a while, I am indeed not as optimistic about ginger being the solution to acute menorrhagia if it's due to a polyp or a fibroid. But I am very optimistic in other situations. And this study was 250 milligrams of a capsule, TID. It's best if you start the day before. So if they have a regular menstrual cycle and we know when that day before is through the first 3 days, that's where the magic is. If you can start it a little bit before. That's true of dysmenorrhea, which I'll talk about in a second. But you get a little head start on those, correcting those prostaglandin mishaps and getting this anti-inflammatory impact that does indeed reduce menorrhagia. In fact, ibuprofen works maybe not even quite as well, about 30% of the time. You can use ibuprofen as well for acute menorrhagia, but the ginger decreased the mean hemorrhage by 46.6%. That's fabulous. 3 times a day, you're going to get a few people who might get some heartburn or something from the ginger. And this, let's see, I'm going to skip over this study and just go right to the systematic review of the meta-analysis of 7 randomized controlled trials. And the dosing ranged in these studies, but very significant effect. Let's just pick out, now I'll go back to the one where they did use 250 milligrams 4 times a day, not 3 times a day, but now 4 times a day. Again, starting this one, actually, they didn't start the day before, although I would recommend it, but starting day 1 in the first 3 days, they compared it to ibuprofen and compared it to mefenamic acid. And the dysmenorrhea severity reduced in all 3 groups. So ginger performed as well as the 2 anti-inflammatories. And in some ways, ginger a little bit better because more women became completely pain-free than in the other 2 groups. So this is a terrific thing to know about. And I would say in botanical medicines for acute interventions for migraines, I don't feel like I have very much to offer at all unless I'm a really good homeopathic prescriber. But in terms of acute botanicals or acute nutraceuticals for migraines, yeah, I'm going to bow to the medications. But here is one little tidbit, just one humble ginger capsule at the onset of the migraine performed as well as the sumatriptan, 50 milligrams. Now, a lot of women's acute migraines are not going to get better with 50 milligrams of sumatriptan. They're going to need a higher dose, or they're going to need a newer fancy triptan, or they're going to need a newer fancy drug that addresses a different mechanisms of migraines. These new drugs that are out, I think one's called Ubrelvy. I might not be pronouncing that correct, but those are great additions to the menu of options. But boy, if ginger could help, then let's try it. And see if it does do the trick. Lots of tradition around using ginger for nausea and vomiting of pregnancy, and that's certainly a historical use as well as an area of published research. Here we have 5 randomized controlled trials. They were all positive. The dosage ranges a little bit. One study, 250 milligrams 4 times a day. Nausea improved in 84% of the ginger folks versus 56% of the placebo. And even vomiting, the vomiting of nausea and vomiting in pregnancy can improve with ginger. We certainly also had some, let's see, did I skip over? No, I guess I didn't. I guess I wasn't going to say anything about that, but there are, I didn't include some other studies on ginger and nausea that have been done with some efficacy, like with chemotherapy, for example, and motion sickness. So it's not just nausea related to pregnancy, but other types of nausea are contenders as well. Okay, let's look at a new herb. Let's look at fenugreek. Why is this in my top 10? Well, we have the whole lactation story, which we'll go over, but there's some other uses, diabetes in particular. So let's look at and then there's a whole list of historical and theoretical uses. But let's look at some of the research here. And this was in menstrual cramps. This is not a very old study, 2014. I actually have not tried this, so I don't have any personal experience. It was an Iranian woman out of Iran. The pain level of menstrual cramps, they had to have menstrual cramps, obviously, to enter the study. They were given either ground fenugreek seed capsules at 900 milligrams 3 times per day, or placebo for the first 3 days of their menses for 2 consecutive cycles. And at the end of the study, the severity of the pain significantly decreased in both groups after the second menstrual cycle compared to baseline. But the pain severity with the fenugreek was significantly less than the placebo. And the duration was of the pain was significantly decreased in fenugreek as well. So I don't know if any of you have any experience using it for that reason, but I did want to call out that study. So lactation. There's case reports summarizing the anecdotal use of fenugreek, and some of those, there's at least 1,200 women reported an increase in milk supply within 24 to 72 hours. That's pretty quick acting results. There's some small preliminary reports also suggest some efficacy. The usual galactagogue dose is between 1 to 2 grams of the powdered seeds taken 3 times a day. That's the usual. Here we have an herbal tea, 7.5 grams of fenugreek seed powder. So that's a bit, that's in that range. Well, that's a little bit higher than our range. But this was also a study that had black tea powder along with, and the control group was herbal tea that was just the black tea. The teas were consumed 3 times a day. After 4 weeks of teas, the weight, the head circumference, the number of wet diapers, the frequency of defecation, and the number of breastfeeding times significantly increased in the fenugreek black tea group compared to black tea alone. So this was sort of using the wet diapers as the measure, you might say, of positivity. But indeed, the number of breastfeeding times did increase, as well as their growth. Well, actually, the growth and height difference was not significant, but feedings improved, wet diapers improved. I guess that's an improvement, right? And some other small reports suggest effectiveness. Fenugreek also has some meaningful research in the area of both type 2 and type 1 diabetes. These, I'm just going to kind of glance over these slides for you to maybe look at later. This one was a fairly low dose, 1 gram per day to type 2 diabetics, compared to just a dietary advice and exercise. And the fenugreek compared well to diet and exercise. A little bit different dosing here, significant improvements in fasting glucose levels and glucose tolerance tests, and were dumping less glucose in their urine. Here's actually, I think should be type 1 diabetes. It should be the header on this slide, not type 2. No, yeah, that's true, type 1. 50 grams, whoa, fenugreek defatted seed powder twice a day, and it was delivered in a bread. The fasting blood glucose decreased from about 80 points. So that's a significant number, still not a great number in the end, but by itself, it had meaningful impact. And then there were some improvements in triglycerides and lipids as well. Here's another one-off, I think from what I can tell, one study only on fenugreek and menopause symptoms. So you might look into that, 500 milligrams twice a day. It was perimenopausal women. So we know that studies in perimenopausal women versus postmenopausal women is challenging because symptoms are more intermittent in perimenopausal women. But nonetheless, their green climacteric scale score, which is yet again another research tool, there was quite a bit of improvement, over twofold improvement from 34 down to 19 in several symptoms: the anxiety, depression, mood swings, insomnia, headaches, and even vaginal dryness. That's a bit surprising. There was also the SF36 score improved in 73% of subjects compared with 32% of the placebo, increase in well-being, increase in mental health. I have not tried this either, but it is a use of fenugreek in women's health. Okay, valerian. I think all of us are aware about its use in insomnia and anxiety. I'll show you a little bit more. The research, though, on insomnia is not conclusive. It's a bit messy in terms of positive and negative effects, but there are trials that show some positive effect on the shortening the amount of time it takes to fall asleep, as well as improving the quality of the sleep. So maybe they sleep a little bit deeper. Here is one of those studies. This is just on women who are menopausal. And what originally caught my attention when I first saw this about 10 years ago was they were dosing it twice a day, whereas I think most of us probably use valerian right before bed. But this was using it twice a day, and about a third of the women had an improvement in their sleep quality. And hopefully it wasn't making them sleepy, that earlier dose in the day. There's also, you do find quite a few studies, valerian with other herbs, lemon balm, hops, see those combinations a lot. This one was just valerian and lemon balm. And they wanted to see if it improved sleep in menopausal women. There were 100 postmenopausal women that had sleep disorders. 50 women got the herbal group, 50 women got the placebo. They were given 2 capsules containing 160 milligrams of valerian and 80 milligrams of lemon balm. After a month, about a third showed an improvement in the quality of their sleep. I'll take any herb that improves quality of sleep, because in menopausal women, it's not just like the kinds of sleep disorders whether they're menopausal or not, that is difficulty falling asleep. I feel like I can almost always help that woman with non-pharmaceutical medicine. But the patient has frequent nighttime wakings, or waking up at 1, 2 o'clock and very hard to get back to sleep, if at all, or the early morning 4 or 5 a.m. Wakers, those are the tougher cases. Anything that improves the quality and the lessening of that nighttime wakings is is a win. And this is where I'm going to say that the testing can really be helpful, whether that's the 4-point salivary cortisol test, or the one that also has the cortisol awakening response test, or the urinary neurotransmitters. Those two tests are where I find special value for sleep problems in women. There was this one study on valerian hot flashes. I haven't seen another one after that. And this was the chief complaint in this study of these menopausal women was hot flashes. And indeed, within the valerian group, they had significantly less severe hot flashes compared with placebo as soon as the end of 4 weeks, and significantly fewer number. There was no change in the frequency number. Does that make sense? Yeah, severity and fewer in number. Okay, let's move on to MACA. And I'm going to especially talk about menopause symptoms and SSRI-induced sexual dysfunction, but it's a wonderful, wonderful adaptogen, high on the list of adaptogens in my book. But we're going to talk about the specific use. And maca is an interesting plant because as I've kind of delved into it to see, wow, maybe not all maca is what I thought it was. And Lepidium, for example, Lepidium peruvianum is just one of 175 Lepidium species. And within Lepidium peruvianum, there are 13 different phenotypes, and each of those phenotypes has a different color, DNA and analytical profile, and even some different physiological effects. So the species and the phenotypes matter, and where it's grown has turned out to matter, and at what elevation. I don't think I have those studies here, but there is a study on that recently that American Botanical Council, I think, published in their Herbalgram. So this is one of the earlier maca studies that I was familiar with, and at 2 months, in this particular proprietary maca product, no significant decrease in hormones and no significant change in estrogen, FSH, any of that. But there was symptom relief at that 2-month marking time. But after, as they used it longer, they did see, wow, the FSH did come down. The LH did go up. There was a small increase in progesterone and estradiol in postmenopausal women. And the mechanism of action, again, this hypothalamic, pituitary, ovarian, and adrenal axis. In perimenopausal women, definitely see this reduction in hot flashes, insomnia, nervousness, depression, heart palpitations, and over 3/4 of the women had that improvement. There is some small amount of evidence that maca can help with sexual dysfunction. This was a very small study, 14 postmenopausal women, but an improvement in anxiety, depression, and improvement in sexual dysfunction. So did it improve their mood and therefore they felt more like having sex, or was it a true hormonal effect on libido? I cannot say. This was also a small review showing, again, some small evidence of the positive effect on sexual dysfunction in menopausal women or adult men that should likely get a different phenotype. So there's that. And in SSRI-induced sexual dysfunction, there's, I think, these 2 studies. This would be a go-to for me in SSRI-induced sexual dysfunction by using maca. And it looks like we really have to use the higher dose of 3 grams a day. And another study showing the same thing, improvement. I don't think they used the same dose. I'd have to look. Apologize. I don't see it here right away. But it was only the postmenopausal women who were taking the maca who had an improvement in orgasm compared with placebo, and only premenopausal women taking the maca who had an improvement in arousal disorder. So it was the orgasm and arousal not the libido that improved in SSRI-induced sexual dysfunction. Okay, cranberry, I just have this one overview slide here, I think, yeah, because I just didn't want to piece through all the little UTI studies because we kind of, I think, all know that. A Cochrane review of 10 studies, cranberry capsules, cranberry juice, or cranberry lingonberry juice, cranberry tablets. So this Cochrane review included all of that. Cranberry products overall significantly reduced the incidence of UTIs at 12 months compared with placebos. They were more effective reducing the incidence of UTIs in women with recurrent UTIs. I think that's where the big plus is with cranberry, is using it prophylactically. So as a reduce in someone who's getting over, really every time they have sex, or 3 to 6 UTIs in a year, let alone more than that. And we all have some difficult cases of women are getting a UTI every 4 to 6 weeks. Cranberry has to be part of the picture. It's not going to be the whole picture ever, I don't think. Especially in postmenopausal women, the treatment plan, in my experience, both understanding the physiology and the anatomy and the research, you got to use vulvovaginal estrogen in those cases. And in elderly women, like older than 65, which I am now officially an elderly woman, which is hard to say. I'm 5 years elderly. But that's also can specifically target benefits in that group. Okay, let's move on to green tea. Green tea also has a nice diversity of uses according to the research. We'll talk about a few of those. So this is looking at evidence. This was a meta-analysis to assess the association between tea consumption and endometrial cancer. They looked at both green teas and black teas. The results suggested that tea consumption was statistically significantly associated with reduced risk of endometrial cancer. An increase in tea intake of 2 cups per day was associated with a 25% decreased risk of endometrial cancer. And if they looked at the subgroup analysis, green tea consumption was significantly associated with decreased risk, whereas the black tea really was not seen. Cheers. Dr. Erin Lohman gave me this cup. Thank you, Erin. And here's a little bit of a mess. You kind of are going to want to look at this study in more detail yourself, because these are 4 different products: the poly-E ointment versus the poly-E capsule versus the EGC capsule versus the poly-E plus the poly-E capsule. They're all different versions of green tea and EGCG, by the way. But if you just kind of put it all together, the overall, there was 69 response rate using green tea in one form or another. And this is part of the story on using green tea suppositories, 150 milligram suppository made at a compounding pharmacy, not homemade, don't do it. Green tea capsule in the vagina, don't do it. Too many allergic contact dermatitis problems. Compounding pharmacy. For HPV, part of my protocol is inserting or CIN1 in particular, or Ascus HPV plus Ascus HPV alone, CIN1, all these, part of the protocol is this green tea suppository twice a week for 16 weeks. I also like to do it 1 month after a LEAP in those who get a LEAP, because it can even help, the hope is that help recurrence of HPV. This has been around for a long time. Basically, stage 1 and stage 2 breast cancer patients, the more green tea they drank, there was a 16.7% recurrence rate for those consuming 5 cups or more of green tea, with an average of 8 cups a day. That's a whole lot of green tea drinking. So I don't know. This is why I'll tell them, well, drink 1 to 2 cups a day. And then, by the way, take these 2 capsules of green tea as well. The Osaki study basically kind of showed us that green tea consumption was inversely associated with mortality due to all causes and inversely associated with cardiovascular disease. It was stronger for women than in men, and it was even greater association for cardiovascular disease. Unfortunately, they didn't see any beneficial effect of green tea consumption, reducing the hazard ratio of cancer mortality. I've been using this idea here from this study for a while now. I'm not really sure that I could say that I really see a noticeable thermogenic effect of green tea in weight loss. But nonetheless, the study shows 2 caps with breakfast, 2 caps with lunch. Hold on. And but it is purported to have this thermogenic effect and improving fat oxidation. Dry mouth. This is, I think, was in patients who had Sjogren's syndrome, and they had these green tea lozenges. I haven't scoped out sourcing of that or anything, but and we might be able to extrapolate dry mouth and use of green tea for non-Sjogren's patients, because dry mouth can be a problem in menopause as well. So here's our 2 pretty cool things to studies on green tea and fibroids. And the first of these was published about 9 years ago, and the second one was much more recent, 2 years ago. But this first one here, all the women had at least 1 fibroid measuring at least 2 centimeters or larger, a total uterine volume of more than 160 mils or more. 22 were randomized to green tea. They took 45% EGCG extract, and they received 2 capsules daily of that. And of the 22 women in the green tea group, significant uterine fibroid total volume reduction of about 1/3. I'll take 33% any day, anytime with reducing fibroids. Also had some reduction in symptom severity related to their fibroids. And then the second study, maybe not as significant, and there was a little vitamin D and a little B6. I think those are irrelevant to the results. In the treated group, a significant reduction in the volume of myomas, reduced by 2 centimeters after 4 months. That's about the same as the other one. They didn't, the number of myomas did not change in either group. They said the improvement in quality of life. So perhaps I misspoke. It's about the same as the other one. So I think we should give it a try. 150 milligrams of EGCG is probably the dose that you want to target. So if it's 45% of whatever's in the capsule, let's say there's 300 milligrams of green tea in the capsule, 45% is EGCG, that's about 150 milligrams, just to help you cogitate on the math there. And then curcumin, I think this is our 10th herb. And this slide is basically the point I'm trying to make is look at all those molecular targets and multiple mechanisms of action of curcumin. It's immense. It's broad. It's kind of like if you're stuck on a remote island somewhere, if you get to choose one herb that doesn't provide calories for food, I think it probably should be curcumin, because of all the things that it does. Just really impressive. Growth factors, receptors, anti-apoptotic proteins, protein kinases, inflammatory mechanisms, enzymes, you name it. And one humble little study on hot flashes, 500 milligrams twice a day. There was a group that had vitamin E as well. The average number of hot flashes in the curcumin group and the vitamin E group was significantly lower than the placebo group. after 8 weeks. The first significant effects started to appear in the curcumin group after 4 weeks. Vitamin E didn't work after 4 weeks, but did have some benefit after 8 weeks. This study seemed to report just on the number of hot flashes, not on the severity, so that's disappointing because we want to know severity. And think about curcumin for endometriosis. This is in looking at a test tube again of the human endometriosis endometrial cells, and how curcumin can downregulate vascular endothelial growth factor. So that's the basis of it, decreasing the expression of VEGF, which is one of the numerous mechanisms involved in endometriosis. Endometriosis is not about hormone imbalance. That's a very, very tiny part of the pie of mechanisms involved with endometriosis. I'm not saying it would be ignored, but to have that be the bulk of your effort is you're going to really miss the boat on helping a lot of women. And we have to look at if you look at the pie of endometriosis, we have the VEGF issues, we have inflammatory problems, we have prostaglandin imbalances, we have deficient natural killer cells, we have abnormal blood supply, so doing anti-angiogenic mechanisms is part of the picture. So we do have some great lectures on endometriosis in our institute weekends. It looks like curcumin might have a humble effect on reducing HPV, so we could think about that. This is looking at curcumin, a meta-analysis in major depression, significant reduction in major depressive symptoms with curcumin compared to control. It also looked like when they parceled out and looked at subgroup, curcumin had a significant benefit in middle-aged patients, but not older patients. Curcumin had a significant benefit if it was treated for more than 6 weeks, but not for less than 6 weeks. 500 milligrams did not have an effect, but 1,000 milligrams did. And it had a better effect in those patients who only had major depressive disorder versus major depressive disorder and other chronic health problems. Curious. So those 4 sort of qualifiers: more than a gram a day for more than 6 weeks, major depression, and in middle-aged patients. This was a second meta-analysis that was just a little bit longer, I think 35 more patients than the first one. And some at least short-term relief of improvement in pain and mobility, and even compared to diclofenac. If there was one study that found if you do diclofenac and curcumin, you can get a little bit better effect than just diclofenac. But is it changing the course of degeneration of a joint? We cannot say that. We can say it improves pain and function. A tiny bit of evidence on rheumatoid arthritis. And this first one was, again, the curcumin versus alone, diclofenac alone, or the combination. All 3 treatment groups show statistically significant changes in their disease activity score. And then fatty liver is another area. Non-alcoholic fatty liver disease is another area, which is a big time brewing primary healthcare problem, women and men, and even I think greater in women than in men, because more women are obese than are men. So this is a important. Fish oils, curcumin, obviously diet and exercise. These are 2 very important players in non-alcoholic fatty liver disease. There's a whole lot of absorption dosing issues with curcumin, and I find it to be confusing, if not irritating. But it is a poorly absorbed herb in the intestines, even at these high doses. So this is why every company that has a curcumin product kind of chooses which of their methods are they going to use to enhance the absorption. Traditionally, curcumin is consumed with peppers to solve this problem. But there are several technologies that I have listed here, and there's even some proprietary water-soluble formulations that with their extraction and dual extraction, they can get good absorption. And there's even a claim that you can improve absorption by synergism with some other botanicals, not just peppers. I don't know too much about that. Okay, and then if, again, maybe especially you want to check out the Institute of Women's Health. And like I was saying, we have another seminar coming up end of July. When is that? July 29th and 30th. We do have a speaker from Doctors Data as well. And we have questions perhaps.